أعوذ بالله من الشيطان الرجيم. بسم الله الرحمن الرحيم. والضحى والليل إذا سجى ما ودعك ربك وما قلى ما ودعك ربك وما قلى وللآخرة خير لك من الأولى وللآخرة خير لك من الأولى ولسوف يعطيك ربك فترضى ألم يجدك يتيما فآوى ووجدك ضالا فهدى ووجدك عائلا فأغنى فأما اليتيم فلا تقهر وأما السائل فلا تنهر وأما بنعمة ربك فحدث صدق الله العظيم.
Thank you so much, Sheikh Ahmed. I would like now to call upon Mr. Malik Almoosa, CEO of Almoosa Group and the Chairman of Health Committee in Al-Ahsa Chamber of Commerce, Board Member of Al-Ahsa Governor Region, Board Member of the second cluster of the newly formed Riyadh cluster as part of the Ministry of Health Transformation Plan, Member Boards of Trustees, Almoosa College for Health Sciences, Member in the International Plant Tree Designation Committee, and a member of the National Health Committee in Saudi Arabia, to give an opening speech on behalf of Almoosa Group team.
Assalamu alaikum. Good morning all, and thank you for joining us on this beautiful day in Al-Hassa. This is a great conference, just kicking off our new journey in oncology services. As you know, Almoosa was driven by a mission to bridge the gap in services in our region. We were the first hospital to open, as a private hospital to open back in 1996, where people was traveling outside of our city just for normal procedures, like normal deliveries, simple procedures. People were actually traveling outside of Al-Hassa to get treated in other regions. Now this is, our services is available, but we continue also to bridge the gap in services from many services that we provide. Neuroscience Center, we were the first actually to offer the region the most comprehensive neuroscience center, and so many other services. Now, the oncology, as you know, not only Al-Hassa, but there is a lot of many regions in the kingdom and across the world. There is a lot of lack of service in this field. There is a lot of patients waiting for many months to get appointments in different regions. And as you know, the suffering of not only the patient, but the whole family while they travel outside of their own city and wait there for a lot of months and weeks just to get the right treatment and to seek the better treatment and options. This is hopefully will be available within their city, so no more patients will be traveling outside of Al-Hassa to get a simple procedure like PET scan or a SPECT or even radiation therapy or advanced procedures or surgical procedures. This is a service that we will all really proud of, and we thank you all for joining us to enrich the discussion and to kick off the new era of Almoosa, which is offering the most comprehensive oncology services. So thank you all, and hope that you will enjoy the tour in the hospital and tour in Al-Hassa, and wish you all the best. Thank you.
Thank you, Mr. Malik, for your nice speech. I would like now to invite Dr. Ahmed Antar, the head of this conference, to introduce you to the conference projects and themes. Dr. Antar is hematology and medical oncology consultant and chief of oncology center at Almoosa Hospital. Welcome.
Assalamu alaikum. Good morning, everyone. On behalf of the organizing and scientific committees, I am delighted to welcome all of you, distinguished speakers, academics, healthcare professionals from the Kingdom of Saudi Arabia, from GCC countries, and from all over the world, gathered here in Al-Ahsa to participate in Almoosa first International Oncology Conference. This meeting is unique. Indeed, it's the first International Oncology Conference taking place in Al-Ahsa region. And this is a very, very special timing for us since we are celebrating the opening of Almoosa Specialist Hospital Comprehensive Cancer Center. We started the medical oncology service in February 2015. And since then, many milestones in oncology patient care have been achieved, including the development of the pathology lab. We get the CAP and AABB accreditation, significant progress in the interventional radiology services, launching of the pediatric oncology service, and the surgical oncology with almost all subspecialties. And most recently, we turned off the circle of multidisciplinary team care by adding the radiation oncology and the nuclear medicine services with state-of-the-art technology that covers all modalities in radiation oncology, in addition to diagnostic and therapeutic nuclear medicine with PET and SPECT machines operated by highly experienced physicians, nurses, technologists, and medical physicists. In the coming 3 days, we will have a rich program covering most frequent or most common adult cancer in Al-Ahsa or in Saudi Arabia, breast cancer, colorectal cancer, lymphoma, leukemia, and almost all pediatric cancers, leukemia, lymphoma, brain tumors, and other solid pediatric tumors. This program will feature some of the world-class renowned international, regional, and national speakers whose scientific work had been well recognized. So today we will start by a breast cancer session focusing on the screening, newest pathological classification, and the management updates in early, locally advanced, and metastatic breast cancer from surgical, oncoplastic, radiation oncology, and medical oncology perspectives. The second session for today will cover the latest data on the management of pediatric brain tumors, lymphomas, and other pediatric solid tumors. Tomorrow, we will have a full day covering hematologic oncology, with a morning session about pediatric leukemia lymphoma and afternoon session about adult leukemia lymphoma and myeloma. These 2 sessions will focus on the emerging therapeutical modalities in the management of blood cancers that includes new targeted therapy, gene therapy, bone marrow allogenic transplantation and bone marrow transplantation, and CAR T-cell therapy. Moreover, tomorrow we will end the second day by a special event, a roundtable cases discussion with Professor Muhammad Kharfan Dabaja, Chairman of Transplant and CAR T-cell Program in Mayo Clinic, USA. And in the last day, on Saturday, we will have one morning session covering colorectal cancer updates from screening approach endoscopic treatment of early stage disease to medical and surgical and radiation therapy for locally advanced and metastatic disease. Furthermore, we will have a parallel session running today in the other venue that will cover oncology topics related to nurses, pharmacists, and clinical dietitians. And there will be tomorrow 2 oncologic nurses workshop. Finally, I would like to thank Almoosa Specialist Hospital Administration, our CEO, Mr. Malik Almoosa, and Chief of Academic Affairs, Dr. Zainab Almoosa, for their invaluable and continuous support to make this gathering successful. And big thanks also to all organizers and scientific committee colleagues who worked hardly in the last 6 months to make this unprecedented event happen in Al Ahsa region. Again, I would like to welcome all of you and wish you an enjoyable and inspiring conference. And thank you. Just I would like to remind you that on the back of the badge you have conference booklet. You can scan this barcode to access the conference agenda. And for the physician track, you have another barcode you can scan to ask a question directly to moderators. And also I would like to remind you that there will be a parallel session in the other venue. So please, for nurses and pharmacists and clinical dietitians who would like to attend the other session, go to other venue. And now I would like to welcome, we'll start our first session, breast cancer session. I would like to welcome our moderators for the first session, Dr. Abdul Muttalib Dandan. He's a medical oncologist from King Fahd Hospital, Hufuf. Dr. Muhammad Al-Duhailib, breast surgeon from King Fahd Specialist Hospital, Dammam. And Dr. Ibrahim Al-Uthain, radiation oncology chairman in King Fahd Specialist Hospital, Dammam. Thank you.
Assalamu alaikum wa rahmatullahi wa barakatuh. Thanks, Dr. Antar, for the invitation and for the introduction. It's my pleasure to start this session with my co-chairs. The first session will be given by Dr. Noor Naimi, who's a senior consultant in medical imaging. She is the director of medical imaging at King Fahd Specialist Hospital in Dammam. She's also director of Mayel Jabr Screening Center in Dammam. Dr. Noor will deliver to us a very interesting talk about medical imaging and breast cancer.
Thank you, Dr. Ibrahim. Yes. Assalamu alaikum jami'an. Thank you, everybody. Thank you for attending. Thank you, Almoosa Group, the organizing committee, the scientific committee, for giving me the chance to see you, learning from you, and sharing with you some of the knowledge I claim I know. Shall I use the flicker? طيب شو أسوي؟ Okay. طيب. Since Dr. Ibrahim was not, voice was not loud enough, I will introduce myself again. I'm just teasing you. I work as a breast and women imaging radiologist in King Fahd Specialist Hospital. نقطع؟ Okay. كذا كويس؟ يدخل فين؟ طيب, the objective of my presentation is to go through standards, guidelines, and assessment and early detection, evaluating the standards that we are using and assess our tool, and going through some of the new trends and their impact on our management. I'll just go through a quick statistics just to know how far we are in managing the breast cancer, and is there a problem or it's just an outside? It's in the globe problem, it's a global problem, or it's just in the Western country and we are away from this problem. Now, if this is an international, worldwide female breast cancer prevalence, and it's related to age as well. As you can see, the breast is almost fourfold in comparison to the next incident in the colorectal cancer. If we zoom our statistics, comparing what's happening outside to the Saudi Arabia or to nationwide, the breast is still number one when it comes to the higher rank cancer. Recently released King Fahd Specialty Hospital annual report. Thank you, Dr. Dama. It was released yesterday. We can appreciate that 44% of the top cancer sites in the Eastern Province are coming from the breast in female, and in comparison to the male cancer, only 17 are colorectal. Also, if we can see here that the ranking of the top 10, breasts account for 28%. Still far? Right. This is showing the distribution of the referral cases stratified by referring site. You can see that Dammam is the highest. Hassa is not far from it. I believe that the rest, we have less number of referral or percentage of referral because they are served by different healthcare provider. If we compare as well the stage that we are receiving patient seeking healthcare service, most of them are ranging between localized disease and regional disease, and we are not far away from the global age distribution. It's still between 40 to 60 years old, with average of 46 years old. Now we know there is a problem. It's not only global, it's even in Saudi, and we have a higher percentage of referral, all related to the breast cancer. So what are the needs? How can we manage this? There is basic needs. You need to detect the disease earlier stage by screening. You have to grant a fast access to the service. You have to treat them by standard of care, and above all, not to do any harm. Let's start by defining how early it is, why we call it screening. Screening, that means you are dealing with a targeted group with no symptoms. So you can detect the disease before the appearance of any symptoms, so they have a chance of less interventional treatment and percentage of cureness higher. Again, we don't do it randomly or according to our experience or the way we used to do it. No, we have references. These are the most common references or standards or guidelines. Most of them are used in management and imaging. Ours, as a radiologist, the mostly adapted is the American College of Radiology. This is a kind of busy slide. Just think of it in zones. This is the pathway we adapted in Eastern Health Cluster at the first Eastern Health Cluster to create a journey of early detection, management, and fast access. The first zone is your catchment area. This is the target area. You invite people, you invite your target people, you detect their eligibility, you do the risk assessment, and stratify them. Our target in any screening system or program is the average risk, not the high risk, not the low risk. That's why we go through the stratification and risk assessment session for every targeted group. After we localize our target, we move them to the screening service. Screening service by mammogram, any screening available center in the cluster are providing the service, whether it's a mobile unit, it's a center, or it's a hospital. Our concern is the outcome of the screening, which is the mammogram report. If it is between 4 and 5, then we should grant a fast access to a secondary healthcare provider to get the biopsy and get the result and send them to start their treatment. Remember, we said we should not do harm. If we are not ready to accommodate all the outcome from zone 1 and zone 2, then we should not establish, because zone 3 is the area where we are supposed to be ready to accommodate all the product of our screening. For example, if I screen 200,000 in 1 year, this is a success. If I have 8,000 suspicious cases, this is another success as early detection. If I'm not capable of accommodating them at the other end, then this is a failure. Right. This is just a quick, remember I said initially we have to define our target, and our target are ladies between 40 to 70 with no symptoms. There is another way of defining the target, which is doing the risk assessment. What is the risk of getting breast cancer in 5 years and lifetime risk? This is one of the model we are using, Gale or COSAC. It's just an online, you can access it. It's a calculator. You can access it, put some data related to the patient, demographic data, family history, and other requested data. Then you will get 2 reports. One indicating the 5 years risk chance of getting cancer, and one is lifetime risk. The one we concern about is the lifetime risk. This is the tool that segregates average risk and above average risk, and I will tell you why. Now, our target in any screening program is the average risk, the patient who have less than 15% of getting the cancer. The remaining will go through a specific pathway. They have their own pathway of screening. Right. The easiest way is doing, or the standard, as I mentioned earlier, is to do the screening mammogram. Now, it's a very simple procedure. It should not take more than 15 minutes door to door. We'll take 2 views for each breast. This is an example of negative mammogram. Right. This is just to challenge you. I'll challenge the surgeon. Don't. Right. This is a case that's seen maybe 1 month back in our screening center, and we found something we thought we detected at an early stage. Can anybody see, surgeon? Right or left? This is right, this is left. Type toward the nipple or toward the pectoralis muscle? Sorry? Toward the nipple? Toward the pectoralis, أو toward the nipple. طيب. بما أن there is 2 different answers, this is reassuring that you will not take my job, so you miss the findings. طيب, now, which one? The one at the outer, or there is another one? Yeah, exactly. It's the one lower. This is an early detection, okay? The outer one is an typical intramammary lymph node. طيب, what to do? We are a rich country, what to do? Shall we go to PET, CT abdomen? Shall we go to the contrast, MRI, diagnostic ultrasound, because she does not prefer mammogram, she's not comfortable with? What to do? No, not ultrasound, it's the standard. Yeah, in radiology we call them appropriateness. You see how appropriate is the tool to do to utilize it. Appropriateness means that it is diagnostic and the amount of radiation are acceptable. As you can see, diagnostic mammogram, this is an ACR, American College of Radiology, an ACR showing high rating, it is more appropriate to use it with a reasonable amount of radiation at the end of the table. While if you check the MRI without contrast, it is not appropriate at all. It is not diagnostic. There is no value, although there is no radiation. So we go through the standards. It's the appropriateness. In our case, it is diagnostic mammogram. Remember, that was a screening mammogram. So we compress the lesion. Obviously, it's a genuine lesion, not a fibroglandular tissue. And then we confirm it, we localize it, we confirm it, it's a 6 millimeter. This is a successful story. Reality is not like this. طيب. It's difficult to read it from here, but an early detection program, the goal is mainly to diagnose the cases as a result of abnormality in mammogram. That means you should not investigate a case and put her under screening while she's coming with the history of pain, endurance, mass. This is the aim of early detection is to detect it in mammogram before the appearance of symptoms. One of the most important things that 15% of cancers are occult in mammogram, despite the fact that till now, since like almost 40 years, screening by mammogram is the gold standard in the practice, but yet there are challenges, and mammogram is less sensitive in minority of the groups. Right. Let me elaborate a little bit about the diagnostic mammogram. Remember, we said when it's screening, it's two views. When you exceed, then it is diagnostic. Diagnostic can be 2D, 3D, compression, magnification, and also can be utilized as a guiding tool in interventional procedure. I'll give some examples. For example, this kind of calcification, you cannot see it by ultrasound, although in this mammogram, it shows me that it is multicentric disease. Khalas, this is. The other thing that can be seen higher there is partially visualized dense lymph node. This is raising suspicion of metastasis. We can see findings as 2D or 3D. I can appreciate more lesions in 3D, which is the tomo. The other way of doing diagnostic is compressing a lesion to delineate borders and to magnify it to see more of the feature of the lesion. Mammogram as well can be utilized to biopsy under stereotactic guidance lesions, like lesions that not seen by ultrasound or microcalcification mostly, or by using the guidance to insert wire for conservative surgery. Going back to the challenges with mammogram, although it's a very beneficial tool, is the density. The more dense breast, the composition D or type D breast, the more challenging, the more missing chance of missing lesions under this kind of dense breast. Remember the case I showed earlier? It was fatty breast. That's why it was catched, sort of. So what shall we do? Yes, the diagnostic ultrasound. It's a very, very useful tool if it is utilized within the right context. We can use it to assess the size. Usually it evaluate or underestimate the actual size in comparison to pathology. We can assess vascularity, which helps in defining or road mapping our axis in interventional approach. It can definitely show us the multifocality, multicentricity of the disease. This is the best tool to assess axilla and presence of lymph node. And of course, it's the best for guidance when it comes to biopsy, clip insertion, and wire localization. Remember this case? We said we have calcification. It is multicentric by calcification, but to us, with a background of extremely dense, most likely this is DCIS, if we miss the axillary finding. Now on ultrasound, we saw an axillary tail lesion, additional 2 lesions at 5 o'clock, and we could characterize the feature of the axillary lymph node. In addition to the guidance of taking biopsy. By standard, not in our hospital only, we label the passes. So each pass has to be labeled as with number. Also, if conservative treatment was the plan, we can use ultrasound to guide us to insert the wire. As you can see, there is a lesion. The whitish thing or the echogenic thing is the clip marker that was inserted earlier, and the linear structure is the wire that was inserted. Right, let's go to MRI. MRI have been misused by us, not utilized properly because it is available and we don't follow the standards. Let's just stick to the standard, we'll be safe, at least in 80% of our cases. The main reason we are using MRI in diagnostic setting is to define the extension of the disease and exclude, which is part of it, chest wall invasion. Of course, there are other indications in breast, like screening for high risk, but within a diagnostic context, it is to assess the disease extension. This is an example, but we'll go through the main indications. It is the chest invasion, disease extension, excluding multifocality and the multicentricity. Sometimes it is bilaterality, axillary involvement, although ultrasound exceed in accuracy the MRI. And we can use it as guidance when lesions are seen only on MRI. This is an example of axillary single nodule with chest wall invasion. You can see as well tethering of the skin. The extension of the disease is both sides, toward the chest wall and toward the skin. This is a single nodule seen on mammogram and ultrasound, but on MRI, we can appreciate the highlighted ones are all, it's a multifocal disease by MRI, which is upgrading the stage as well. This is, unfortunately, this is unhappy story. Maybe Dr. Dehailib is aware about it. This is a young patient, 26 maybe, presented with mass. So she has whatever is white or high signal is the disease. So it's a multicentric disease. MRI showed the linear structure, which is a linear enhancement within the muscle. So there is chest wall invasion. Since she's young, it's expected to have a dense breast. Remember the composition D? It was extremely dense. Nothing was seen by mammogram, not even by ultrasound. She's unfortunate that she has a multifocal disease on the contralateral side, which was not seen by both ultrasound and mammogram. In those cases, we have to do MRI-guided biopsy, and this is one of the utilization of MRI. Yes, sure. 2 minutes? الحين بدأ يحلو الكلام طب I'll go fast with the contrast. It's basically giving contrast and imaging the patient, starting with the area of concern. If she's having a disease on the left, we'll start imaging the left side when we start after the contrast by 2 minutes. I'll go through some cases very quickly. This is a known case of breast cancer, but the background is extremely dense. So we wanted to know if there is anything else hidden within the dense background. Yes, there are multiple nodules toward the nipple, so it's a multifocal disease. This is another example. This is a known case of right breast cancer post-mastectomy, presented with a newly developed lesion or shadow or density. On ultrasound, it shows a feature suggestive of cyst, so it is benign. However, she's a high risk, and there is a dense background. You cannot risk it. On contrast, 2 lesions seen on the contralateral side, highly uptaking the contrast, highly suggestive of cancer. This is a known case of DCIS. It's a known case, but we still appreciate some of focal asymmetry, unexplained. On contrast study, it shows a high uptake. This is another focus of the disease and an invasive component. Again, the indication of contrast mammogram given or applied because we know this is a cancer, but the background is extremely dense. We don't know if there is anything hidden and not seen by ultrasound. It shows another focus of the disease higher up, so it's a multi-centric disease. I wanted to skip this, like in her nice case. This is a known case of cancer post-surgery. The radiobake line indicates line of surgery with newly developed density. It's a distortion as well. You can see that it is distorted, pulled, and relatively it is related to the scar line, but we are not sure. With contrast, there is nothing. So we are assured this is a fibrosis within a healing scar. This is recently seen. Maybe our team in KFSH are aware of this case. This is a case referred with a clip marker indicating that we have done the biopsy and clip it, so it's a cancer-proven case. On our institution, we imaged the lady. We suspected another nodule just higher to it. With ultrasound, we appreciate the nodule, we biopsy it, it is cancer. So she has 2 nodules detected by ultrasound and mammogram. Now, our concern was the contralateral side. We're not happy about this. The usual pattern, alignment of the parenchyma, is pruning toward the nipple, like the one you see in the below here. But what's happening there that they are pulled somewhere. The alignment is distorted. This is confirmed. This is the 2 lesions we are seeing, along with smaller pattern of enhancement. I'm not sure if this makes any sense to you, but I'll try to explain it further. You can see that there is uptake. The whitish spots are an uptake of contrast. This should not happen. It should appear like the one below. Confirmed on CC. It's unfortunate. By MRI, we confirmed that she has bilateral multicentric disease. Does it replace the MRI? It should not replace the MRI, but recently, because we cannot be guided by contrast to take biopsy. We can see things by contrast, like there was no tool to guide us to take biopsy to confirm the presence of disease. Recently, we can. So it's a very promising tool. It's a fast access, cheaper, and you can access it for interventional procedure. I'm done. Let me just put some points very important that we should treat every patient individually. It's not one size can fit everybody. Our priority should be giving the care as per standard. We do have a lot of tools, like in the idea and the smartness is not to use all the tools. I should not bring my patient to do for them PET because I have PET. This is not the way we should manage. And each patient, each individual should have an individual approach. I'll just conclude. And I cannot read من الجنب. Breast cancer is not preventable disease, but controllable if detected at an early stage. The guidelines criteria address the image workup of women with different stage of breast cancer specifically, regarding which image test should be done to rule out unexpected metastatic disease. Individual case specific approach need to be considered as a management strategy. Precise disease extension, which is the main reason we are doing the imaging, is an initial or essential step in the management. The more you see, the more you can manage. Thank you.
Thank you, Dr. Noor, for this elegant and informative presentation. So our next speaker is Dr. Hamid Al-Jawad, consultant pathology and director of the Specialist Hospital. Dr. Hamid will present an update of HER2 testing in 2022.
Yes. Good morning. Thank you for inviting me here to talk today about HER2. We need the slides. about interpreting HER2 in breast cancer in this year, 2022. During this talk, in less than 20 minutes, I will discuss the changes that happened to the significance of HER2 since it was discovered, and then I will discuss quickly how the labs can assess HER2, mostly in immunohistochemistry because that's what I do, and then we will see how the labs can produce consistent, reliable results, and finally, I will discuss the latest guidelines that were published by the American Society of Clinical Oncologists and College of American Pathologists in scoring and reporting HER2. Sure. And I can't see, so that I have to move. In the 17th century, a French philosopher said, doctors put drugs of which they know nothing into bodies of which they know less for diseases of which they know nothing about. Today, this definitely has changed toward precision medicine, and targeted therapy is the future mega trends. Herceptin, a HER2 targeted therapy, was first approved for treating HER2 positive breast cancer in 1998. And since then, data accumulated showing that HER2 negative breast cancer can show low level of protein expression, and newer therapies arrived and tried in clinical trials, showing that some patients may improve with newer therapies. In August of this year, okay, sure. عشان تكون الأمور واضحة. Okay, testing. Are we okay now? Okay. Okay, thank you for the help, and we apologize for this technical issue. I will continue. On August of this year, a newer targeted therapy was approved by USA FDA, and this is the first targeted therapy for HER2 low breast cancer for metastatic and unresectable breast cancer. In the next few slides, I will discuss what is the meaning of HER2 positive and what is the meaning of HER2 low breast cancer. HER2 is a gene located in chromosome 17. It encodes for a protein which is present in the cell membrane of epithelium. The normal epithelium expresses extremely low levels of protein, and when HER2 gene is amplified, HER2 expression will be overexpressed in the cell membranes. HER2 positivity is correlated with aggressive breast cancer type when, if not treated by HER2 targeted therapy, it will have poor outcome. For therapeutic purposes, primary breast cancer is classified into based on hormone receptor status and HER2 status into HER2 positive disease, which is happening in 15% of breast cancer. The remaining breast cancers are HER2 negative, sorry, HER2 positive. In the lab, we have two gold standard methods to detect HER2 result. The immunohistochemistry and in situ hybridization. In immunohistochemistry, it is applied on formalin fixed paraffin embedded tissue. It utilizes antibodies that will target overexpressed protein receptor for HER2 in the cell membrane. It takes about 2 hours to complete this procedure and about 1 day to report. In situ hybridization also can be applied on formalin fixed paraffin embedded tissue. It utilizes DNA probes to identify HER2 genes in the cell nucleus to identify gene amplification. And it takes about 8 hours for this procedure to complete and about 2 days to report. The guidelines for HER2 testing have been continuously evolving to meet the changing clinical needs. HER2 testing was first approved in 2000 for immunohistochemistry and in situ hybridization, and since then many changes happened in 2007, 2013, and finally in 2018. The changes are mainly to address concerns regarding the definition of positive and negative disease and to address false positive and false negative results, and finally in 2018 provided recommendations when to repeat HER2 test if the result was negative in core biopsy. The guidelines historically and until now focused on separating HER2 positive from HER2 negative breast cancer. Now in this graph, which is the latest guidelines approved by the American Society of Clinical Oncologists and College of American Pathologists, it is based on validated immunohistochemistry and in situ hybridization procedures to determine the level of HER2 protein overexpression and gene amplification respectively. For immunohistochemistry score 0 and 1 plus, this means negative HER2 result. Immunohistochemistry score 2 plus means equivocal result, which would require a reflex in situ hybridization test to give us a negative or positive result, and sometimes it can also give an equivocal result. Finally, score 3 plus by immunohistochemistry means positive HER2, and it will be eligible for the usual HER2 targeted therapy, Herceptin. Now, what the pathologists see under the microscope for each score is defined by this criteria. For immunohistochemistry score 0, it is either flat negative, no staining, or very rare, barely perceptible, incomplete membrane staining in less than 10% of the tumor cells. For immunohistochemistry score 1 plus, there is faint, barely perceptible, incomplete membrane staining in more than 10% of the invasive cancer cells. Score 0 and 1 plus are negative by this criteria, which is the latest criteria. Immunohistochemistry score 2 plus, which would show weak, weak to moderate membrane staining in more than 10% of cancer cells, or strong complete membrane staining in less than 10% of the invasive cancer cells, and it means equivocal result. Immunohistochemistry score 3 is the only score that would go for treatment by HER2 targeted therapy, which shows straightforward, strong, intense, complete membrane staining in more than 10% of the tumor cells. But now this is changing because we know there is a spectrum of HER2 expression which is beyond positive and negative. Now, although 85% of HER2 breast cancers are identified as negative, we know that 50% of breast cancer, the metastatic breast cancer and recurrent and unresectable breast cancer, they show variable level of HER2 protein expression in the cell membranes. And because we know that there is a new treatment that came in August of this year, which is approved for these cases, we need a clear guidelines that will tell us how to identify HER2 low breast cancer cases to be eligible for this new treatment. On the left side here, we have proposals from the published data. Those cases with immunohistochemistry of score 1 plus without need for in situ hybridization, and those with immunohistochemistry of 2 plus are most likely going to be considered HER2 low breast cancer in the next guidelines. Few data also suggest that even those with immunohistochemistry score 0 that show minimal staining, they may also be eligible for this treatment, but this is not sure for now, and they would like to call these as ultra-low HER2 expression. Now, how can we in the lab can give you consistent and reliable immunohistochemistry results for HER2? First, before offering this test for clinical service, we must validate this test. Validation means you need a number of cases that you run in your lab showing or should match the results that were done in another lab. The other lab should be previously validated for this test. For now, the CAB guidelines require 80 cases to go through this procedure. Half of them should be HER2 negative and the other half should be positive. You should use FDA approved kit with known sensitivity and specificity, and those cases that you run for this validation should conform with all the guidelines that we'll discuss in the next few steps. After having a validated test, there are a number of variables that you must standardize to have improved results. In the pre-analytical phase, the focus is toward having optimal tissue requirements, meaning first, you should use only 10% buffered formalin because it is the only fixative that is approved for clinical HER2 testing. Second, you should have ischemia time of less than 1 hour. Ischemia time is the time that is between acquisition of the tissue by the surgeon until the time it is placed totally and submerged in formalin. This time very likely to be very short, 1 minute or less if this is a core biopsy, but if this is an excision or mastectomy, the time will include transportation from the OR to the lab, grossing, sectioning, and having 5 millimeter thickness tissue. And finally, the fixation time. Fixation time is the time for the tissue that remained in the formalin, and it should be between 6 and 72 hours, overfixation or underfixation will result in a number of false positive and false negative results. Now, in the analytic phase, you again should use an approved kit with known sensitivity and specificity. And for each run you run for the cases of your patients, you should have working positive and negative controls. The post-analytic phase is the time where the slide reaches the pathologist for interpretation. The pathologist should be trained how to score and recognize artifacts, and they should undergo quality assurance with ongoing competency assessment with proficiency testing material from outside your hospital. And for best practice, a second pathologist should read for borderline and challenging cases, meaning immunohistochemistry score 1 and immunohistochemistry score 2 results. The lab should conduct trend analysis for their results annually to see if they are belonging to the international benchmark. The report must include distinct immunohistochemistry score and should report the intensity and the kit and primary antibody clone number used. And the report should also include the pre-analytic variables that are the ischemia time, fixation time, and type of fixative used. Now, you should repeat HER2 if it was negative in the core biopsy in the following condition. If the tumor in the core biopsy was grade 3 and it is negative, you should repeat the test in the excision. If you have small tumor volume in the core biopsy, repeat it in the excision. If the resection shows high-grade carcinoma that looks completely different from that high-grade carcinoma in the biopsy, repeat the test. If the core biopsy shows HER2 result negative, both in situ and immunohistochemistry, repeat it in the excision. And finally, if you suspect that there is a problem because the tissue came from outside hospital and you don't know anything about the fixation time, ischemia time, and type of fixative, repeat it for the benefit of the patient and according to the guidelines. Now, in conclusion, HER2 is a prognostic and predictive biomarker for treating breast cancer. HER2 is primarily evaluated to determine eligibility for treatment. And the current guidelines interpret HER2 as positive and negative, but we know now that there is protein overexpression that would benefit from newer therapy, and we are awaiting for newer guidelines that will tell us how to define and identify protein overexpression. And finally, those with immunohistochemistry score 0 are unlikely to be treated with the newer therapies. Thank you.
So now we move to our next speaker, Dr. Abdulatif Al-Sharif. Dr. Abdulatif is a consultant in nuclear medicine at Almoosa Specialist Hospital, and he will present molecular imaging of breast cancer. So please, Dr. Sharif.
For this nice presentation. Thank you, everybody. I hope you hear my voice. So can we start? Do you have my slides, please? Okay. So my talk today will be about molecular imaging of breast cancer, the current status and the future perspectives. Currently, we have, as most of you know, we have two radiopharmaceuticals that are widely accepted by most clinical guidelines in the management of cancer. These are fluorodeoxyglucose, better known as FDG PET, and sodium fluoride PET, better also known as NAF PET. Okay, now, more recently, another radiopharmaceutical has been approved by the FDA, which is known as fluoroestradiol, FES-PET, and this is gaining momentum now in nuclear medicine. Other radiopharmaceuticals do exist in the clinic, in research laboratories, namely fibroblast activation protein. I bet you we will see it coming very soon in the clinical practice. Epidermal growth factor imaging agent, which is known as trastuzumab, labeled by zirconium, and programmed death ligand, also, which is known as atezolizumab, PDL1 agent, is also in the cockpit of nuclear medicine. I will not be discussing everything. I will be focusing on FDG, NAF, FES, and FAPI. Now, all of us know FDG, but a reminder for those who are not who do not know what is FDG. FDG is an analog of glucose. Most cancer cells consume glucose and consume it a lot. Why? Because a normal cell uses 1 molecule of glucose to produce 38 energy molecules, 38 ATPs. A cancer cell does not do that. A cancer cell uses 1 molecule of glucose to produce only 4 ATPs. And this means that it needs lots of glucose to build itself and to generate more energy. What is FDG? FDG, it is an analog to glucose. It's taken by the glucose cell, by the cancer cell, and accumulates because the cancer cell is not able to degrade it furthermore. So that's why a cancer cell accumulates FDG, and that's what we use in nuclear medicine to image our patients. So our first lecturer told us about appropriate use criteria. In order to get a useful information from a PET scan, you need to know when to ask for a PET scan. Do we use PET scan for invasive, for diagnosis of cancer? We don't use it. Of breast cancer, we don't use it. Do we use it for non-invasive DCIS or LCIS? No, it's not indicated. We use it in some cases of invasive breast cancer. According to the NCCN guidelines, we use it in staging, stage 1, 2, 3, and 4 breast cancers, only to solve problems, only when we face equivocal cases. A lung nodule that we are not confident, is it metastatic or not, so we ask for a PET scan. A bone lesion that's sclerotic, probably metastatic, we ask for a PET scan. This is the NCCN guidelines. Now, patients with inflammatory breast cancer have very avid FDG uptake, and these cases must do a PET scan, and the PET scan in this case can replace a CT with contrast and can replace bone scan. So if you do PET scan for these cases, no need for bone scan or no need for CT scan. On the other hand, lobular cancers, as you might see there, is characterized by low FDG uptake. And low FDG uptake means that the sensitivity of the PET scan is limited. So you don't do PET scan for these cases. More recently, the Royal College of Physicians and the Royal College of Radiologists from the UK published this paper. It's evidence-based indications for the use of PET-CT in the United Kingdom 2022, published just a few months ago. And they're telling us that FDG PET, again, is performed only in equivocal cases, particularly before therapy, and in staging patients with inflammatory breast cancer before surgery. But they go one step further, and they're telling us PET-CT is suggested in patients with T1 breast cancer, because T1N1 or T2N0 breast cancer, and is strongly recommended. Now, this is novelty. This is strongly recommended in patients with stage 2B or more breast cancer. It is suggested in patients with aggressive tumor pathology, such as triple-negative cancer, and it can replace other imaging modalities when we can't perform them for other reasons. For example, allergy to contrast or renal impairment. The French and the Italian societies of nuclear medicine published before that, before the British, the same recommendations. They are telling us that PET scan is optional in stage 2A breast cancer, and it is highly recommended in patients stage 2 or B breast cancer. We are not using it anymore as problem solver. We are using it in staging. Why is that? Because approximately 30% of stages 2B cancers are upstaged if you use PET scan. And this will this will definitely change the management of our patients. Now, we did the PET scan.
Can we get more information from this PET scan? Of course. Dr. David Grohu, since the early 2010, tried to pay our attention, drag our attention to the prognostic value of PET in breast cancer. It has been consistently reported that ER-negative cancers have higher FDG uptake, higher SUVs. PR-negative cancers have higher FDG uptake. HER2 does not affect FDG avidity, and this has been also consistent in the literature. The most consistent thing to know in the literature is that triple-negative cancers have higher uptake than non-triple-negative cancers. Histological grade 3 cancers have higher SUV values. P53 mutated cancers have higher SUV values. This actually ends up in a summary that has been consistently reported in the literature and summarized in this meta-analysis over 3,500 patients. And in this meta-analysis, they have two important conclusions. High SUV is related to higher risk of progression, and low SUV is related to better survival outcomes. So the SUV value itself has a prognostic power. This has been demonstrated very nicely in this paper published recently. And in this paper, they took 125 female patients. They used the SUV. They tried to find a threshold where we can identify which patient can perform better than the other. And look at the curve here. An SUV, that the line in green, is an SUV of 8.6. And these patients are doing much better than patients who have higher SUV values above 8.6. So SUV of 8.6, which most of the time correlates to a grade 3 cancer, a triple-negative cancer, to start with, when you do it at diagnosis, you can predict that this patient is not going to perform very well. Other indications for FDG PET cancer is evaluation of neoadjuvant therapy response, chemotherapy response, particularly again for triple-negative cancer and HER2 cancers. It is very useful in assessment of treatment response to systemic therapy, particularly for those patients who have diseases that are not easily detected by other cancers, such as bone metastasis. A bone metastasis is not easily detected on CT or on bone scintigraphy even. So use PET scan not only to assess the presence of disease, but to predict its or to demonstrate the response to chemotherapy. And in treatment of patients with complex metastasis, multisystemic metastasis, where sometimes some metastases respond better than other metastases, so you need a PET scan to identify how tumor in different sites is responding to this kind of treatment you are delivering to these patients. Now, the prognostic value of FDG PET also has been studied in several papers. This is a paper that was done on over 1,630 patients. It's a meta-analysis. And again, we have two important conclusions in this study. It's interim and end of treatment PET is significantly associated with pathological response, and metabolic response to neoadjuvant therapy is a significant prognostic factor in terms of disease-free survival and overall survival. This is true for interim and for end of treatment PET. Yet, I need to draw your attention for one thing. When you as a clinician try to assess the response of the tumor in the breast itself, the breast lesion itself, we can use PET for interim evaluation. It performs, this dark line performs much better than MRI in the interim situations. But at the end of treatment, we still recommend MRI to assess the response to chemotherapy. So at the end of treatment, MRI actually outperforms PET when we are talking about the breast lesion itself. Assessment of recurrence. Can we use PET to assess recurrence? Of course. Conventionally, we use CT scans and bone scans, but yet we can use PET scan to solve problems. That is, again, a lymph node that's suspicious, and PET then will solve the problem. A patient with a negative conventional imaging and elevated markers, what better than PET that you have that can solve this problem? Differentiation of treatment-induced brachial plexus plexopathy. It can be a tumor infiltrating, or it can be neoplastic. Again, this is a role of MRI, but nuclear medicine can play the role to solve the equivocal cases. This is an example. A patient with plexopathy with the hotspot determining confirming malignant infiltration. In the absence of FDG activity in the brachial plexus, we can actually confirm that this patient does not have neoplastic infiltration of the brachial plexus. So I need to cut it short for the FDG because I think most of the clinicians know a lot about FDG, and I'm proceeding to other tracers. NAF PET scan for bone. It's a scan for bone. It's a bone PET scan. It has the same principles, the same pathophysiology of bone scan that we already know. But it has higher contrast, low background. So NAF has been available since the 1972s, before the advent of PET-CT. You know that the PET machine existed in the early 1960s, but it was fused with the CT in the year 2000. So we have FDA approval of NAF for detection of bone metastasis since 1972. And it is included in most clinical guidelines as an alternative to stage bone metastasis, particularly when we have crisis of technetium shortage, as the one we are having now. NAF bone scan actually is the most sensitive technique. Its sensitivity approximates 100% to detect bone metastasis. It's more sensitive than the conventional bone scintigraphy. It is more sensitive than FDG PET, but it is with this increasing sensitivity, we are sacrificing to a bit some specificity. So it is sensitive because it can detect most osteoblastic lesions, and it can detect them quite well. But it has a limitation. This limitation is known as the flare phenomenon. I'm sorry you can't see that. Now, the flare phenomenon is increased activity of the lesion on the scan because of bone repair due to the osteoblastic activity. This is a limitation of FDG, of NAF PET, that is not there for the FDG PET. One important thing that I need to remind you about is that FDG actually performs very well in detecting bone metastasis in breast cancer. It can replace bone scintigraphy and NAF PET scan if it can detect metastasis on both the PET component and the CT component of the study. So my question, it is very sensitive. You're telling me it's very sensitive. It's not as specific, and it suffers from the flare phenomenon. And I have a bone scan, and technically it's conveying the same information. When should I do PET? And this is a very fair question by the clinician. This study aimed to answer this question, and they are giving us two suggestions. You do PET when you have sclerotic lesions in a bone scan that are not avid, they are not hot on a bone scan. You see them also in an FDG PET scan. You're still suspicious, and they are not avid on FDG either, and you're still suspecting this could be metastasis. So you do an AF bone PET. Another scenario is that you have a patient with breast cancer with a single oligometastatic bone lesion. You want to treat that radically. So what would you do? You need, before going through radical treatment, you just need to confirm by the most sensitive technique that you have that this is actually an oligometastatic lesion. Okay, enough for bone scan and bone PET. Let's go for the more recent tracer, which is known as Cerianna. Cerianna is a fluoroestradiol agent. It is a PET agent that images estrogen receptors. Now, Cerianna has been available in nuclear medicine laboratories for more than 30 years by now. But a company from France known as Anexa has produced a stable molecule, and it got the FDA approval in the 2020, few months ago actually. And the approval is like this. Please read with me the approval. Approved for the detection of estrogen-positive lesion as an adjunct to biopsy in patients with recurrent or metastatic breast cancer. So this is what Cerianna has been approved for. And this comes with a limitation. The limitation is that tissue biopsy should confirm recurrence, and the estrogen receptor status should still be confirmed by pathology. So we are not yet replacing pathology. Why do we need to image estrogen receptors in a patient with breast cancer? Clinicians know, because there is heterogeneity in estrogen receptor expression within the tumor itself, between different foci of tumor, between the primary and the metastasis, and even a lesion itself, with progression of treatment, with medications, can it change its estrogen receptor status. And this can be up to 40% of cases in heavily treated patients. Now, this is an important paper and one of the papers that led to the approval of Cerianna, of FES PET. It was published in Lancet Oncology 2019, and it proved the safety of FES PET, but it had a very interesting feature finding. Over 85 patients with breast cancer, they analyzed PET, FES PET, with estrogen receptor status. And the negative correlation was 100%. So if FES PET tells us there is no estrogen receptor, then there is no estrogen receptor. Unfortunately, positive correlation was only 76%. And that's why the condition, that's why the limitation. You need still to confirm the presence of estrogen receptors by histopathology, even if you do Cerianna PET. Okay, when do we use FES PET? This paper, published in Journal of Nuclear Medicine, tries to answer this question. They tell us you do FES PET to solve problems. What kind of problems? Inability to identify the extent of metastatic disease, unclear estrogen receptor status of the tumor, or inability to determine which primary tumor caused metastasis in patients who have more than one tumor. The paper demonstrated that FES PET actually can solve most of the problems. That this blue line means the problem solved. So most problems were actually solved by FES PET. And this is really fascinating. We have now a tool that can guide us through the management of patients. This is an example. This is a patient with bone scan and ankylosing spondylitis and breast cancer. You see the hot spots there in the spine. I'm, as a nuclear medicine physician, and I consider myself as an expert, I would have passed that as degenerative changes easily in a patient with ankylosing spondylitis. The clinician in this case has the power to add FES PET to his exam, to his patient, and he sees all these hot spots in this patient. So this is a patient who has breast cancer metastasis, and FES PET could solve the problem. So, nothing comes without drawbacks. This is an FES PET, again, imaged as you can see. See the liver, how hot the liver is? You can't see a lesion in the liver with this hot liver. So, FES PET scan still cannot identify liver metastasis. We need another tool. Another important question in breast cancer is, can FES solve the problem of limitations of limited FDG sensitivity in lobular breast cancer? The answer to this question is really difficult. We still don't have enough literature to answer this question. But this is a very important paper that tried to answer this question, published just a few months ago, or 1 year ago. Now, it is a head-to-head evaluation between FES PET and FDG PET. It is a retrospective study, but its data came from 6 prospective papers. They identified 92 patients of breast cancer who had FES PET and FDG PET. Of these 92 patients, only 7 cases had lobular cancer, and only 7 cases had both scans without intervening treatment. These are the images of these 7 patients. I brought you all the images. The upper row is for FES PET. The lower row is for FDG PET. As you can see from our first 5 cases, the FES PET identifies more disease. All these hot spots on the PET means disease. It's much better and much superior and much more specific even than FDG PET. The last 2 cases, it's the other way around. Let's look at the last case. The last case, the patient has liver metastasis that was not detected by FDG PET. Of course, I told you why. Liver background really is a problem in FES PET. On the other hand, the 6th patient had bone metastasis that was detected by FDG PET and not on FES PET. This means that the patient's metastasis actually, this is good also piece of information. The clinician will take advantage of this piece of information. Metastasis here will not respond to anti-estrogen treatment. And this patient is losing the estrogen expression of the metastasis. So although the scan is negative, still we have clinically useful information from this scan. And the conclusion of this paper was FES PET compared favorably with FDG PET in patients with lobular cancer. It's a powerful tool that we have. I hope we can add it soon to our clinical armamentarium here in Saudi Arabia and in our region to help in the management of breast cancer. Now, another important useful value for FES PET would be assessment of the estrogen receptor.
Dr. Abdulatif, you have
تعطي
2 minutes.
دقيقتين ثلاث. Okay. Now, is the assessment of estrogen receptor availability after treatment and prognosis. This is a patient who has this is before treatment and after treatment. Most of the lesions have disappeared, other lesions did not. It means that the clinician has 2 alternatives. Either change it, escalate the treatment, change it, or go towards radiation therapy. Now, the last important tracer that I will take about is FAPI. FAPI, it images fibroblast activation proteins on tumor cells. And FAPI is expressed on CAF, which are cancer-associated fibroblasts. And these represent 90% of the tumor mass in most case scenarios. And it is characterized by rapid clearance from the background. This is a FAPI image. This is an FDG image, and this is a FAPI image. So you can see the breast lesion, how it is very well expressed on a FAPI. FAPI actually has proven superiority in detection of breast cancer and in detection of brain metastasis because there is no activity in the brain. In detection of bone metastasis, hepatic metastasis, and lymph node metastasis in patients with breast cancer. This is an FDG PET, and that one is a FAPI PET. Look how nice the FAPI PET images look. So this is going to add to our clinical armamentarium. Some clinicians now are trying to label fatty with molecules that can burn the tumor from the inside in the field that we're now calling as theranostics. So this is an added value for our PET scan. Does FAPI solve the problem of lobular breast cancer? This is the only paper that I could find in the literature that targets FAPI and intraductal carcinomas. And as you can see there from the last 2 boxes, that there is no difference in the uptake of SUV between lobular and ductal cancer. So this means that FAPI can solve to us the problem of lobular breast cancers. Again, we are now having some clinical studies. This is one of the most important studies known as the Impact MBC study that's trying to evaluate that each patient with breast cancer should have FDG PET, HER2 PET, and estrogen receptor PET in order to enable the clinician to target each lesion specifically. We are all curious and waiting for the results of this study. Our society, the Society of Nuclear Medicine, is encouraging clinicians to investigate more on lobular cancer. I advise you all to start investigating FAPI and induce FAPI to our clinical practice soon in Saudi Arabia. And even people like Bill Gates are opening their eyes towards nuclear medicine and new radiopharmaceuticals in nuclear medicine. He has just established a company to produce radiopharmaceuticals. And let's read together the motto of the company: supporting the transformation of the fight against cancer by advancing the next generation of isotopes. So this is the motto of his company, TerraPower. And this is where medicine is going, towards molecular imaging, towards personalized treatment of cancer. Thank you. Thank you all.
Thank you very much, Dr. Abdulatif, for the nice presentation and thorough presentation. So it gives me a great pleasure inviting the next speaker with no further delay, Dr. Yazan Masanat. Dr. Yazan is a consultant oncoplastic breast surgeon at Aberdeen Royal Infirmary Hospital, and he's also one of the associate postgraduate deans at NHS Education for Scotland. He is an honorary senior clinical lecturer at the University of Aberdeen, and he is an tutor with the University of East Anglia, if I'm correctly pronouncing it. He is one of the board trustees of the Association of Breast Surgery, as well as a member of their education and training committees. He is the communications lead at the iBreastNet, which is, I have the pleasure to be part of it also. And he is being an examiner at the European Board of Surgical Oncology and European Board of Breast Surgery exams also. There are a lot of things to mention about Dr. Yazan, but I have limited time. Dr. Yazan, we have 20 minutes presenting the oncoplastic surgery, pushing the limits of breast surgery. I wish this is an enjoyable time. The floor is yours, Dr. Yazan.
Thank you for the presentation, and thank you for inviting me, both of you, Dr. Muhammad and Dr. Hanan, to be part of this conference. We'll wait for a couple of minutes because there was issues with my talk. It works on two computers, but I hope it will work on the main computer. The talk, I've tailored a 45-minute talk down to 25 minutes. So you tell me when to stop. I was told that the first talk will be mainly entertaining more type of talk with lots of videos. So there will be lots of videos towards the end of the talk, and we can cut some of those videos. So as mentioned, I'm one of the surgeons in Aberdeen, and I do also have some other roles in the UK and in Europe. And I run the iBreast Book webinars. Those are free educational webinars for anybody that wants to do breast surgery. The only reason to mention them is that some of those are sponsored by the companies, and there's no conflict of interest, and there's nothing to declare. The sponsorship has no relation to this talk. So when we talk about oncoplastic breast surgery, we need to start from the beginning. And breast surgery before oncoplastics was mainly mastectomy and breast conserving surgery, 2 operations. And then oncoplastics came, which is the new kid on the block. It came in the 1990s, and the first description of that was by Aldrich. But things have developed big time in the past 15, 20 years. And what we do now is completely different what was done 20 years ago. So where do we start? When you start any story, you need to start in the beginning. And William Halsted, mastectomies were done before the days of Halsted, but Halsted that has put a method to the madness. And it was extensive surgery because it was the only option for locally advanced disease. And if you've seen a Halsted mastectomy, you will not see those scars anymore. So this is one of the patients that came to one of my follow-up clinics, and you can see the scar is up and down. You can see that the pecs have been removed. You can see that there is loss of the fold there. But mastectomies, the first bit of oncoplastics is to do a good mastectomy. Mastectomies nowadays are different. You should aim for a neat scar, you should aim for a low scar, and you should aim for a flat chest. And if you cannot do a good mastectomy, you should not be doing any breast surgery, because this is better for the prosthesis for the patient. This is better for the patient because you cannot see the scar when they were a low top. And when you do your future reconstruction, it's better to have a low scar. So something along those lines. But mastectomies are better now. We can do a good reconstruction, but nothing will replace the breast. So for example, I'll give you just some few examples. This is a lady with a Paget's disease, had a subpectoral implant, good symmetry in her when she wears her top. Another lady on the days that I used to do subpectoral with keeping the nipple, the right side, and he had to remove the nipple on table because frozen section was positive. And this is a lady with bilateral augmentation that have done a prepectoral mastectomy on the left side and put an implant. With the free flaps, you also can get some good results, which is this is a Dieppe flap. This is another Dieppe flap on the left side with a nipple tattooing, and this is a Dieppe flap. When you push the limits with the plastics, you can still can keep the nipples with the Dieppe flaps. And when we plan the mastectomies, you need to think about the mastectomy and the type of the patient, the type of mastectomy that will be doing, the patient and the cancer treatments, and trying to avoid this. We all have complications. If you haven't seen complications, then you haven't operated. This is a dead flap, and this is a nipple. This is an implant that has extruded. So I'm going to mention a couple of things on top of the mastectomy, mainly about skin nipple sparing. In the past, people were dubious about doing any reconstructions, immediate reconstruction, but the data suggests that immediate reconstruction people do as well. The chance of overall survival and recurrence is the same. And if you keep the skin, that does not affect the local recurrence or overall survival. So in certain cases, you can keep the skin. You need to be very careful with extensive DCIS and tumors that are close to the skin. But in general, it'll give the patients far more superior result if you keep the skin. And there is lots of papers. This is one from Carlton about 10 years ago. They summarized the data of local recurrence in skin and non-skin mastectomies. And you can see there is some, the local recurrence rate is quite low, but there's lots of caveats and bias in the selection. We're not going to go through that. A couple of examples how you do your mastectomy. So you can do it with a circumareolar ellipse, and you can get this result which you've seen before, or when you put an implant, you get something along those lines. Or you can do a Weiss pattern. It's a bit more tricky and more challenging to do a Weiss pattern mastectomy, but usually it works well. And always try to keep the nipple. If you can keep the nipple, it's gaining popularity. It does, when you do it for a BRCA positive patient, it does lower the risk reduction from 95% to 90%, but they give them far more superior aesthetic outcome, and there is no data to suggest that it is not safe. In fact, all the data suggests that it is at least equivalent. It's not always suitable for all. For example, we go back to this lady of the bilateral mastectomies. Unfortunately, the frozen section on the right side was positive. I had to remove the nipple, but remember, not everybody will agree with this. The nipple is not the areola. So some people remove the whole areola, but you really don't need to remove the areola. Some ladies have a 5 and 6 centimeter areolas. If you remove that, there's not much skin left on the breast. And some ladies, you can give them better aesthetic outcome when you do the mastectomy. Now, the type of reconstruction, we're not going to go through that because there's lots of things to talk about the type of reconstruction. We'll concentrate a bit more about breast conservation because this is where we can push the boundaries to try to keep breasts. And we know all the data from years ago from the Milan trial and from the trial by Fisher and SAB B06. And we know that the 20-year follow-up data on breast conservation versus mastectomy is equivalent. So we don't need to argue that breast conservation is safe. In fact, the new study by the Swedish cohort showed that some ladies with breast conservation might do even better than mastectomy patients. But in the past, all the RCTs have included large tumors. So if the Milan study was only up to 3 centimeters tumors, some of the studies went up to 4 centimeter tumors. So not all T2 tumors were included. They excluded, of course, locally advanced tumors, inflammatory cancers, multifocal, multicentric breast cancer, and central tumors. And you'll start questioning why. So it's mainly because years ago, it was quite new to them. They did not know as much about oncology, and they felt it's not safe to operate on those patients. And also because of cosmesis, you'll get those results sometimes when you do bigger excisions. So that's why people were shying away from conserving those breasts. But that's where we start pushing the limits. Things have moved on from the 80s and the 90s, and things are much better nowadays. Your technology is far superior. Radiology is better, and we had lovely talks about radiology before. Pathology is better, and we had lovely talks about pathology also before. And oncology is better. We have much more targeted treatments. So let's look at all those exclusions one by one. Large tumors. Many papers have boasted about excising large tumors. There is no RCTs. We will never have RCTs about large tumors. But this is the paper from Chris Shraklov. And you can see up to 16 centimeter tumors were excised. Also, the term extreme oncoplastic surgery has been started by Melvin Silverstein, which is mainly excising anything more than 5 centimeters, T3 tumors. And there is, if you look at the local recurrence rate in that cohort, comparing the extreme and the standard breast conservation, it's very similar. And we all have those patients. This is a lady with an 8 centimeter phylloides tumor that was offered a mastectomy, but you can easily do a small vertical scar, remove the 8 centimeter, reshape the breast, and still keep her breast. And I always put this case because this is the first case when I started as a consultant, wanted to conserve an 8 centimeter area of DCIS in a hospital that used to do mastectomies for all those patients. And you just need the radiologist to be able to put the wires for you, bracket everything, you know that your excision is fine, and you get a reasonable aesthetic outcome. Now, locally advanced cancers, there's many that are not operable, so don't venture into operating. Some are operable. This is a malignant phylloides was growing by the day, and this is also a metaplastic carcinoma, but you need to choose your battles. You need to choose who you can operate on, who you cannot operate on. And some locally advanced cancers, by definition, they can be just going through the skin, but they're still conservable. So not all locally advanced cancers are locally advanced cancers by the definition that we think of. Central tumors, also they excluded central tumors because of aesthetics, but there's lots of techniques. You can do a central simple ellipse. You can do a Grisotti flap, or you can do a Weiss pattern and remove the nipple, and that will give you a nice shaped breast. It's much better than having a mastectomy. And we'll have some videos about those if we have time in the next 5 minutes. Now, multifocal, multicentric breast cancer, we're not going to go through this. This is another 20, 30-minute talk. I do conserve some ladies with multifocal, multicentric disease. This is our paper from 2 years ago giving our thoughts about multifocal, multicentric breast cancer. And we've done another study looking at the global variation of conserving multifocal, multicentric breast cancer. And you find that nearly 2/3 of people believe that this is conservable in certain patients. The most important is to plan, because if you fail to plan, then you're planning to fail. And there's lots of factors. You're not operating on a breast. There is patient, there's a tumor, and there is the breast itself. And of course, there is us, the surgeons. Not everybody will be able to do everything. So we need to choose our battles. The patient factors, common sense is not always common. Things like age, comorbidities, habits, especially smoking and drinking, and profession are very important when you choose the patient and the operation. And you need to manage expectations, because some ladies think that they're having aesthetic surgery. They are not. They're having cancer operations. Even if you're doing it in a reduction, it's a cancer reduction. It's not cosmetic surgery. And the breast, they come in different sizes and shapes. There's a small breast, there's a very large breast, there's ptotic breast, skin quality is important, previous scars, previous radiotherapy, patient wishes, and the contralateral breasts. And always think about biology, because if you don't understand biology, you should not be doing breast surgery. So, site in the breast, biology, and other treatments. Just a couple of small examples. So, this is a lady with a 3 centimeter tumor, luminal A, node negative, so she needs surgery first. Will your surgery be different if she's non-smoker, fit and healthy? Will it be different if she's a smoker, fit and healthy? And will you consider something else if she's heavy smoker, uncontrolled diabetic on steroids? So it's the same breast. It's a different patient. It's a different operation. For the first fit and healthy, I'll do a mammoplasty Weiss pattern. For the second, I'll de-escalate a bit. I'll go for a lateral mammoplasty. For the third, she is high risk. Things will fall apart. You'll go for a simple wide local excision. And what you can do for the lady on the left-hand side is completely different than what you can do on the lady on the right-hand side. So this is a lady that if she has a 3 centimeter triple negative breast cancer, will you do things different if it was 3 centimeters of microcalcifications with DCIS in the upper outer quadrant, or 3 centimeters of microcalcification with DCIS centrally? So this is an actual lady that had a 3 centimeter triple negative breast cancer. She had her chemotherapy, and this is her post-op results, because she already had complete response. I've done only the clip out, and you can see symmetry. But if you started with the surgery, then you will not achieve that. If she had microcalcifications with DCIS in the upper outer quadrant, it's either a mastectomy with implant, or you can do wide local excision with chest wall perforator flap to fill that, and I'll show you a little video about that. But if the microcalcifications is central, then she needs a mastectomy, maybe with an implant. While this lady, if she had multifocal, multicentric disease, do you really want to do a mastectomy on one side and leave her with 1.5 kilos on the other side of breast tissue? So this lady had a multicentric disease on the left side. She had bilateral reductions. So lots of things to think about. You need to balance lots of factors. Always remember your oncology. If there's indication for chemotherapy up front, just give it up front. and try to decrease your complications by choosing your patients, improve aesthetic outcomes, and your aim is to do less mastectomies for patients that want to keep the breast. You'd want to avoid those results. Scar placement, we're not going to talk much about that. All what I'm going to say is that always plan your mastectomy when you do your wide local excision, because 3% of your patients that have mastectomy will need wide local excision will need a mastectomy at the end. So always remember that the majority of the patients will need a simple operation. 70% of patients will need a simple wide local excision. Don't complicate things, and always manage expectations. So for level 1 oncoplastic surgery, we're talking about dual plane mobilization. This is from the Krishnakloff famous paper, to be able to close a defect. And when you look for the scars, I usually don't cut on the breast. I usually do a periareolar incision, maybe a little lateral extension like a wine glass, sometimes inframammary incision or lateral incisions. And if there is a bit of asymmetry between patients, sometimes you can do a little crescent to improve those asymmetry. This is a lady that had wide local excision, and unfortunately there was large area of DCIS unexpected. So because I planned my surgery, I've done an inferior inframammary fold incision, I managed to do a mastectomy and implant-based reconstruction. If the cut was on the breast, then you will not get this result. But remember, many ladies, all what they need is just a cut on the breast, take the tumor out. If they need a completion mastectomy, they don't want reconstruction. A couple of videos, and here if you need me to stop, you tell me when to stop. Do you want to play the first video? You need to play it from your side. That's great. So central wide local excision, a simple thing to do. There's central tumors. What you do is you need to cut on top, cut below, and just go down to the fascia. So you do your cancer excision first. It's the first thing is you do your cancer surgery. You go down to fascia. And once you do your cancer surgery, you always leave the metal clips for the radiation oncologist so that they'll thank you when they do the radiotherapy. And after you do the cancer excision, it's very important not to just simply close the cavity, because that will flatten the breast. It will not look good. You need to mobilize the whole breast a bit in dual plane and close it in dual plane. And I usually close the gland in those patients if the gland is dense enough to take the sutures. If it's very fatty tissue, I wouldn't put the suture there. And then I'll close in 2 layers. I always sit the patient up a bit on table if there is any doubts about the ptosis, because this is a young lady in her early 30s, and the last thing you want is to have 2 different looking breasts. So let's see. Oh, sorry for that. So we'll go for the next video. Do you want to see? No, sorry, yeah, that's great. Sorry, we missed the last bit of the first video. So the second video is a Grisotti flap. It's a simple dermoglandular flap. Those are little videos that might be of importance not only to surgeons, also to oncologists, especially when they do their radiotherapy. Sometimes to pathologists to see how we do our excision. So you keep the bit of a dermoglandular flap. This is a central tumor. Then you do your oncology excision. The same principles. You go down to fascia. You do your excision. You do your x-ray to check that all is okay. Then the flap is a simple flap. It's a dermoglandular flap. You just need to mobilize the breast tissue. You need to go down towards the chest wall, because the blood supply will come from the lateral intercostal artery perforators. And you need to release things for things to close. For the surgeons here, it's very important not to close under tension, because that will not look at the end. It will not look good. So always mobilize as much as you need to mobilize. Put some clips. Check that it looks okay on closure and there's no tension at all before you start closing. Always do your hemostasis, and always put the clips for the radiation oncologist for them to do the radiotherapy for you.
2 minutes, Dr. Yazan.
That's great. Then we'll skip this. We'll do a round block. Yeah, do you want to start the video? And we'll cut it halfway through. The round block, very simple also. You just need to deepithelize the skin. And I usually use scissors to deepithelize the skin. And then when you open the planes, you need to open you have done that deepithelialization, so you need to leave so small part of that deepithelialized skin for you to be able to retract on and to be able to suture on. And then after you do this bit, then you think about oncology. You go on your oncology planes, you do your excision, but always when you go on the oncology plane, before you do your excision, you mobilize laterally and medially a bit more to be able to close the defect. Always when you deliver the wire, you put an artery clip on that, and you deliver the wire with a controlled manner, otherwise the wire can move and you lose your tumor. You go down to fascia, I always go superior and flip the specimen down, and then when you excise that area, you always mobilize things medially and laterally to close the defect, and then most of the time I try to put the marking stitches for the pathologist when the specimen is still in the breast, otherwise you'll get the wrong marks. And I'm going to skip half of that. The closure will be in 2 layers, and I'll close the gland. And there's quite a few other videos, so we're going to skip the lateral mammoplasty. It's a simple operation also. We're not going to go through that. We'll just go through a little, also there's a nice omega, but because of time, we'll just go on only for the Weiss pattern for now. And the Weiss pattern, where you do the surgery, is not in theater. Where you do the surgery is before theater when you plan the patient, because you cannot do any of this in theater when the patient is lying down, especially with a bigger cut breast. And remember, you can do a superior medial pedicle and remove the whole lower half of the breast. You can take 5, 6, 10 centimeters out of a big breast. Sometimes you take 1 kilo plus of breasts. It's not unusual in Scotland to have a K-cup breasts. And when you do an inferior pedicle, you can take the whole upper half of the breast. And that's where you do most of your surgery. I always tell my trainees, if you're not there for the marking, then you'll never be able to do that operation. The excision is very simple. Yes, it takes about 1.5 hours each side excision, and another 1.5 hours for the closure, because the closure takes long time. You can see the bracketing wires because it's a larger tumor. They epithelize sometimes with the skin and sometimes with the scissors, and we'll just show the lower half is all being taken off. And there's a video that is only 20 seconds.
Absolutely yours.
So this is, the whole lower half will come off. Sorry for that, it's because of time. We cannot show everything. And the last thing, which is the new kid on the block, is mainly the chest wall perforators. I don't know if this video will work. No. Can you play the video from your side? It's not working on this side. It's a 20-second video just to show you one little thing about chest wall perforators if it works. So chest wall perforators is a simple operation. It's not difficult to do. You just need to know where your vessel is, and you can dissect half of the chest wall and put it in to reconstruct the flap. I think the video is not working from there, so that should be okay. Then, thank you for putting up with me for the past 20-25 minutes, and thank you.
Thank you very much, Dr. Yazan, for the nice presentation. And now it's my pleasure to introduce my colleague and friend, Dr. Sameh Hashim, who is a senior radiation oncologist at Almoosa Specialist Hospital. He's the head of radiotherapy services. He will talk to us today about updates in radiotherapy for breast cancer. Enjoy the difference, and I'm sure you will enjoy the great talk.
Thank you so much, Mr. Chairman. Assalamu alaikum. So, in general, a couple slides to just explain exactly what we're talking about and what's radiation, what we're doing. So in general, this is the target volume where we give radiotherapy. Usually we treat the whole breast, and we add on top of that the axillary lymph nodes, level 1 and 2, sometimes the internal memory lymph nodes, and other than that we add the infraclav or the level 3 axillary lymph node or the supraclav. So that will be given in 2 different separate fields. Those will be, the lower one will be targeted in 2 tangent fields and the upper one in a direct field. So radiotherapy is delivered in 2 different regimens. The conventional regimen, which is the usual regimen that we give at least 25 treatments. So it can be given in different ways, but it's going to be like more than 5 weeks. And the other regimens is the hypofractionated regimens, meaning giving lesser dose of radiation, lesser period of radiation. This is called the moderate hypofractionation, where instead of giving 5 weeks of treatment, we go to 3 weeks of treatment. And we have now what we call the ultra hypofractionation, where we give radiotherapy in 5 days. So we moved from 25 treatments, 5 weeks, into 1 week, 5 days. So add to that, we boost the tumor bed. The booster dose, we look at the tumor bed itself, where the disease was, and we include the scar where it was resected with the margin. This is what we call a boost. And the boost can be delivered in like 4 treatments, 5 treatments, on top of the conventional field. So the length of the breast treatment moved from 5 to 6 weeks to 5 treatments. So we always know that it's safe and efficacy of breast conservative therapy, meaning doing breast conserving surgery followed by radiation. It was confirmed in phase 3 randomized trials and gave an overall survival comparable to mastectomies. Add to that, after mastectomy as well, there's a good also outcome from radiotherapy in local relapse, where it's less compared in patients with local regional recurrence, and in the first recurrence also giving radiotherapy would add a benefit over mastectomy indicated cases, and as well as breast cancer mortality. So what really happened? What are the updates? What really is going? So we know that the radiotherapy is effective in terms of conventional way. So when conventional radiotherapy started in 1960, afterwards we had the first hypofractionation treatment in 1970, where they give like randomly, not evidence-based, different type of short courses of radiotherapy. Those resulted in very extensive late toxicities. And from here, there was like in the 70s and 80s, increase in radiation-induced injuries in those patients in UK. And some over a period of 10 years, and some of the patients, they reported like about 40% having complication like brachial plexopathy. So afterwards, the UK, there was a women group called RAGE that really brought up this issue, and that mandated the National Health System in UK in order to ask the Royal College of Radiology could conduct a study or a follow-up or investigation to see what is the optimal hypofractionated or short course of radiation that really would prevent having those complications. And here comes the genesis actually of the START-A and START-B trial. The START-A trial and START-B trial is a very comprehensive, organized study that looked into different regimens of radiation, comparing that to the conventional fractionation regimen. So they compared the 25 treatments over 13 treatments in different scenarios, and the START-B as well did compare the 50 grays and 25 over 40. So they reported very excellent outcome in local control. So the shorter radiotherapy is comparable to the longer radiotherapy in terms of disease control. And people say that hypofractionation of breast cancer is the patient advocacy achievement. That's true, because without that group of RAGE patient, nobody would go and tackle the shorter period of radiotherapy. So the breast hyperfractionation started also back then in Canada, where they conducted several studies till the clinical oncology group. They developed a protocol 42.5 degrees 16 fraction, and that also was in a very clinical organized trial, randomized, where they reported data of 3 years, 5 years, and 10 years, and with all the, they have a local good control data and the cosmetic outcome as well. So because of the good outcome and the result, it was in the ASTRO, Radiation Oncology, American Association for Radiation Oncology, they adopted the radiotherapy short regimen, okay, for patients who more than 50 years, early stage, did not receive chemotherapy. But in 2018, this recommendation also included the UK recommendation, 40 grays and 15 versus the 25 and 42 and 55 and 16 fraction. But they generalized the inclusion criteria to have any age, any stage with any chemotherapy regimen. So, but what's really interesting is those patients who had nodal disease. So do I give radiotherapy with short period of time with hypofractionation to those who had nodal disease? So this is a report of all 3 STAR trials. They looked into that case of patients, and they reported that adjuvant hypofractionation after surgery is very safe in long-term outcome. That was confirmed again in a Canadian study that compared the hypofractionation regimen in the UK and the Canadian to conventional treatment, and they reported that it's really safe and efficacious. And in the Italian study as well in 2022, also they reported that there's no toxicity, there's no grade 3 acute skin toxicity at early stage. So it's safe even to give radiotherapy in a very hypofractionated way over 15 treatments for those who have nodal disease. That's good. But here come the UK study that reported 5 treatments only. And that was in 2022, where they compared the UK hypofractionated regimen to 2 different short course radiotherapy regimens, 27 grades and 5 treatments, as well as 26 grades, 5 treatments. And they had that, and most of the patients did, not most of the patients, 25% of the patients get a tumor boost. And they followed the patient for 71.5 months, over 6 years, and they found that the 26 grades and 5 fraction had better result compared to the 40 grays in 15 fraction and to the other regimen. So, and we look here at the in-breast recurrence, it was less in the 26 grays and 5 fraction. And given, because at the same time we had the COVID pandemic, the recommendation was to go for shorter radiotherapy regimens in 5 fraction for those who had no negative tumor and do not require any radiotherapy boost. So, and again, the use of the hypofractionation in 5 regimen went from 0.2% to 60% utilization of those patients. So it's very good achievement that we're now starting to shorten the period of radiotherapy. But again, we're still interested in the lymph nodes of those who received lymph node irradiation. And the Fast Forward trial reported just recently in 2022 the nodal sub-study of their groups. They collected all the patients who received radiotherapy to the nodal area with the 5 treatment courses and reported the result. And the result was very comparable to the moderate hypofractionation regimen, and it seems to be that the arm lymphedema and complication as well as the swelling of the hand is less compared to the hypofractionation. So it's really safe now to give radiotherapy for patients with short period of time with even lymph node involvement. This is a detail also about the outcome of those patients and reported data. And we can see that it's comparable and have the same outcome results. So when you go to the major international guidelines right now and see what they recommend. So in the ASTRO and ESTRO and Royal College of Radiology and the NCCN guidelines, they all recommend the moderate hypofractionation regimen for patients with whole breast radiotherapy after breast conservation, for breasts who had mastectomy without construction, and for those who had mastectomy with construction, and even for those who have lymph node involvement to give the moderate hypofractionation. But still the 50 grays and 25 fraction, the conventional is not used anymore. So we're not using this regimen anymore. We're keeping it for special situation where we have like giving concomitant chemotherapy or patient has special comorbidities. So no one is using any conventional dose given the treatment of breast cancer in any of those guidelines. Again, only the UK and the European guidelines reported the use of short 5 treatment recommendation in whole breast radiotherapy and chest wall irradiation, and only the UK did report using this regimen in those who have construction breast surgery. And again, there's another hypofractionated regimen that we recommended for those who have lymph node involvement in the Royal College group. So still, the UK actually is recommending 5 treatments in every scenario. It's safe, it's been shown that it can be done, but still, it's missing the expertise, the recommendation. You cannot really do this type of treatment without have a good machine, with respiratory gating. And since this dose is like a stereotactic dose, 5.2 gray per fraction, I think more measures of controlling the breathing pattern of the patient need to be taken into consideration. So we'll not really expose any normal tissue to that high dose. So there's another also regimen from the old FAST pilot, which gives 28.5 grays in 5 fractions over 5 weeks. Only 1 fraction per week was assigned to patients with significant comorbidities and patients who cannot really make it on a daily basis for radiotherapy. And the other thing, should I really boost or not to boost? Is it important when I'm using a very short course of radiotherapy? Should I give a booster dose or not? So again, the booster dose, as I said, this is a tumor bed with an additional dose after giving radiotherapy to the breast. And there are indications to boost those diseases for patients less than 50 years and those who are from 50 to 70 should have high-grade tumors, and those with positive margins. And criteria for omitting the boost is possible as well for patients who are more than 70 years, ER, PR, hormone receptor positive, low or intermediate courses, and widely negative margins. And the booster can be given also while giving the 5 treatments or while giving the breast treatment or after, called sequential or concomitant or simultaneous integrated boost. So the boost delivered clinically that in the study looked at the patient with negative margin, and they have 2 arms, given the conventional treatment with a boost, and they gave like no boost to the patient. It's well known, well known to patient that giving the boost would give benefit for those patients, especially those who are less than 40 years in age, with the added benefit of 17%. But when we go to hypofractionated regimen, adding in the boost, it's a little bit tricky. There comes the UK study here in 2018, when they give they boost sequentially and concomitantly with radiotherapy, and they have really good, excellent outcome compared to the cosmesis and the way the breast looks without really major complication. 84% have no change in the breast appearance in the boost that given sequentially, and for those who were given concomitantly with the boost in the 15 fractions, were about 88 and 83. And again, there's another study been reported recently, and those patients have been given hypofractionated 15 treatments. They also were given a boost concomitantly, and they have the same outcome. So going to the fast-forward trial, the one which recommended 5 treatments, here we only, 25% were given boost. Those who are less than 40 years of age with tumor who had lymphovascular invasion or grade 3, or those who have poor prognostic factors. So not all the patients are eligible for the boost while you're giving the shorter course of radiotherapy. So when you go to the recommendation, I would go with the study recommendation. So when you give conventional hypofractionated, moderate hypofractionation, you can give 16 grays 8 fraction either sequentially or 48 centigrade 15 or 54 concomitantly with radiotherapy. When you give the Canadian protocol, you still can give sequential boost, 12 grays or 14 grays in 6 or 7 fraction. And when you go to the hypofractionation, you can give 10 gray of 5 fraction or 16 gray 5 fraction. So we can also use the concomitant boost from the UK hypofractionation in the Canadian hypofractionation. But nobody knows if we can do concomitant boost for the ultra hypofractionation in 5 treatment. So it would be safe to give the 10 grays and 5 fraction following the 1-week treatment. And again, the inclusion criteria for the boost for the ultra and moderate hypofractionation would differ from the age and depending on the presence of prognostic factors. So in conclusion, it's a moderate hypofractionation. With the Canadian or the UK protocol, it's now the standard of care. No one is using the 25 treatments anymore, so we go with this recommendation. Ultra hypofractionation, giving the treatment in a shorter period of time over 5 treatments, is not anymore considered as experimental. That need be included in the clinical practice. People need to include and think about it very seriously, since it really would help patients, especially in the pandemic situation. But add to that, this is very high dose. Breathing need to be controlled. Highly sophisticated machines need to be used when you want to give this kind of treatment. And the booster dose indication can be delivered sequentially or concomitantly, as we said. And we're still in the hyperfractionation only, I would recommend to give it in the sequential manner. So still we need longer follow-up for the fast forward to think about nodal disease. I'm not sure whether it's time now to step in and give the short course in 5 treatments for those who have nodal disease. Thank you for your attention, and hopefully I did not really bore you with my lecture.
Thank you so much, Dr. Sameh, for the great presentation. I think it's time for the questions and answers. Dr. Muhammad will lead the discussion.
Thank you so much, Dr. Sameh, for the brief presentation. I think you gave us 5 minutes extra so we can put it on the discussion side. For the audience, you can check that there is a QR code on the back of the ID card for any questions. So you can submit your question electronically and we can have it here. We'll have a discussion. So we can kindly invite the speakers to the stage, please. Dr. Anur, Dr. Hamid, Dr. Yazan, Dr. Abdul Latif, and also Dr. Sameh, please. So the floor is open for discussion, and as the moderators also, we have some discussion points for many of the presentation. It was nice presentation. I will start with ladies first, as usual. So the question to the radiology, Dr. Noor Naimi. The question came as, how can we modify the international guidelines for breast cancer screening for average risk populations according to our population? We see patients younger than 26, less than 30-year-old ladies presenting with breast cancer as average risk. So do you recommend that we have to have our guidelines in comparison to the ACR or NCCN guidelines recommendation?
Thank you. Yeah, so far